Well, Renew, how are you?
I'm good, Declan. How are you?
All good. Busy studio this evening.
It is busy. It's very crowded. I love it. No one on Zoom. Everyone's here in person.
I totally love it. And welcome back to friend of the podcast, Nathan Lawrentschuk, of course, founding member of this podcast, really, Nathan. Thanks for coming back in.
Always great to be here, Declan and Renew.
Nathan
Still in your scrubs?
Yeah, straight from theatre, unfortunately. We had to get here on time.
Absolutely.
Nathan is a urologist at Peter Mac and director of urology at the Royal Melbourne Hospital, and an expert, one of our national experts on penile cancer, which is I'm delighted to say is the topic of today's podcast.
I love doing topics that we know nothing about, Declan, because it's a good opportunity to learn something.
Is this the first full podcast we've done on penile cancer in 5 years?
It's got to be.
Wow. There you go. We describe ourselves as a GU oncology podcast, yet this orphan cancer has never even featured on it. 200 odd episodes. And
it's about time.
It's about time. And I suppose the reason why, Renew, is of the other guest we have in the studio, Professor Asif Muneer is visiting from London, from UCL in London. Asif, great to see you. Thanks for popping in.
Well, yeah, I've been watching the podcast and I thought I'd make a personal visit and travel all the way here and do it live.
Well, because penile cancer hadn't been discussed. So he's like, come on.
Thought, better rectify the problem. Well, you've inspired us, Asif. Welcome.
Pleasure.
Yeah, so Asif, are you currently head of urology, director of urology at UCL?
Yes, I'm the clinical lead for the urology department. We're the biggest urology department in the UK.
In the UK, wow.
And also we're one of the biggest penile cancer centres as well, which is why we're experts in this area with both the clinical aspects and the trials.
So just by way of your own personal background, so that is your interest, andrology, including penile and testis cancer. That's been your long-standing personal interest. You've been head of BOUS, andrology, etc. You've got a lot of publications and research in this area. So the perfect excuse to talk about, penile cancer mostly really is what we want to talk about today.
Nathan, it's an interesting concept, isn't it? Because Asif just said that they're the penile cancer centre. That's not a term we often hear here in Australia.
No, and centralisation largely is a dirty word here because all urologists here are equally trained and, we have busy regional centres and so on. Although I have to say, certainly by default, I think a lot of places in Australia do have centralised penile cancer services, particularly for things like organ-sparing surgery and node dissection. There are not that many urologists who have exposure to that. And, I was lucky enough doing an SUO fellowship in Toronto. And of all people, I learnt sentinel node biopsy off Laurie Klotz, who's obviously famous for prostate cancer. But when I worked with him, he said, Nathan, you've got to learn this sentinel node thing. It's fantastic. He taught me, and then Neil Flesh, my other mentor, he was doing the penile cancer at Toronto General. So it was on a GU oncology fellowship. That was just something that I just picked up almost by accident, not intending to do. And then when I came back to Melbourne, not many people were putting their hands up to do it. And pretty much myself and Justin Chi in Melbourne do the lion's share of work of this rare malignancy. But we'll probably talk about this in a little while, but there are still centres that will do the primary. There's dermatologists, plastic surgeons, and some urologists, and then we have to pick up the pieces a little bit later because sometimes they haven't quite had the pathway of management that we would prefer. But it's been an interesting journey. So,
Renew, that's part of what we want to talk about. There's a few things we want to get through, including, I suppose, state of the art about surgical management, organ conserving surgery. In the old days, lots of patients were getting really, very mutilating surgery, and hopefully it's much, much less so now in select cases. That's one thing. Lymph node dissection is a really important part of penile cancer, isn't it? Always has been, but, who needs it? What about,
sentinel nodes, superficial versus deep, unilateral versus bilateral.
Minimally invasive nowadays. So, these two gents are big experts in node dissection. The issue of centralization you've touched on and we'll get back to. And then, Nathan, we're going to wrap it up towards the end by talking about this really interesting project that I know you've been working on for years and years and years. This idea of having AI to help with identifying pathologies based on imaging and so on. And you've got a project that's nearly there. So, stay tuned for news about the PECR database. Yeah, it is. It's a real serious project. It's taken many years and it's nearly there. But Renew, before we dive into it, let's talk about the rarity of this cancer, because we were looking this up beforehand. And, if you want to hear about rare cancers in a country the size of Australia with about 28 million people, how many cases a year, penile cancer cases a year do we see?
Yeah, we looked it up. It's less than 120 a year.
Compared to 25,000 prostate cancers.
Yeah.
So, what's that, like 120 a year, only one or two a week, some weeks.
I mean, it is rare. I mean, even in the UK, it's only 750 cases a year, but there seems to be a significant difference between the two countries.
Asif, tell us about that. So, it's just simple maths, just doing my maths here, right? Australia, 28 million, UK, 65, 70 million. That incidence looks way higher. It's about it's still very rare cancer, but 700, 750 cases a year versus 100 odd here. Is that truly a difference in incidence? Please explain.
I mean, I'd expect the incidence here to be relatively similar in terms of the proportion of cases. If you're a population of 28 million, would be probably about 300 cases. Now, one of the problems that we had in the UK before centralisation was the recording of the cases. So there's a lot of subspecialists dealing with penile cancer. So dermatology, even GU medicine, plastics, we're all dabbling in penile cancer. But once you centralise it into 12 centres around the UK, there's better recording of data. And that's where we found that in 2002 with improving outcome guidance, that once you're centralised, the number of cases recorded jumped from 300 to about 600.
Wow.
So just reducing the number of centres got better recording. So I think that might be the issue here, that because you've got no centralisation and there's lots of centres dealing with penile cancer, that it's probably getting underreported.
What about the vaccine, the HPV vaccine? Because Australia was one of the first places to get that in 2013. I think you've written here.
For boys, yeah. Teenage boys from 2013.
Yeah, for boys. Would that explain it?
Probably not yet, because it'll take about 3 decades to see the impact of gender-neutral vaccination. I mean, Australia's got to be congratulated because it is one of the first countries that had gender-neutral vaccination. I mean, the UK, we were late in the game. We started off with girls only. And then MSMs, and then obviously from that led on to gender-neutral vaccination. So it will have an impact. I mean, obviously, we know that 40-50% of cases are HPV related. It won't eradicate it completely, but I think, in about 3-4 decades, we'll probably see the incidence reducing. It brings me on to the whole idea of lichen sclerosis, which is probably going to account for the other 50%.
Right.
So early diagnosis of lichen sclerosis, treatment, circumcision will probably reduce the incidence even further. So I think they're the two main drivers.
Yeah.
But it's really interesting about lichen sclerosis because if you read some of the older textbooks, they virtually say that, there's a very low risk of penile cancer with it. And it's traditionally, certainly in this part of the world, been managed largely by dermatologists and with steroid-based therapies or by GPs, which is fine, except that, the real cutting edge teaching is 6 weeks of high dose steroids. If that doesn't work, maybe another 6 weeks. If that doesn't work, you need to move on. And I think people don't understand that a circumcision actually cures the lichen sclerosis.
It does, yeah. So, I mean, you get a period of euceratinization over a 3-month period. And even if you've got pre-malignant disease on the glands, performing circumcision, you tend to find that once you follow them up after 12 months, and we did our study on it, that a lot of the pre-malignant disease actually goes.
Wow.
So you don't even need topical treatment. You don't need to give them topical chemotherapy or steroids or immunotherapy.
Circumcision.
It just goes. Yeah, circumcision is the cure.
Well, lichen sclerosis is also known here as BXO, still for its old name, Balanitis xerotica obliterans.
That was a great name.
Which so it sort of it gets lost a bit too because there's nomenclature.
Yeah.
So is that an underappreciation in primary care mostly then? Should this be getting spotted a bit earlier on? And tough, isn't it? I mean, genital dermatologist is quite a difficult specialty to access in many countries.
How common is it?
Oh, look, lichen sclerosis is very common. I mean, I don't have a percentage figure, but it's common. And I think it often goes down that dermatology pathway and has done. And as urologists, we get referred the ones where they're certainly refractory to steroids.
Yeah, no, I agree. I mean, dermatologists are probably the first port of call. A lot of the time, the general practitioners will diagnose as a balanitis fungal, give them antifungals. But there are very subtle changes. And if you are a dermatologist with an expertise in genital dermatology, you'll pick up the signs of a little bit of loss of the architecture of the corona, scarring around the frenulum. It doesn't have to be a tight foreskin that you can't retract. There are some subtle changes. In fact, I was out for dinner with one of the sort of leading genital dermatologists in my stay in Melbourne, Chris Bunker, one of my colleagues at UCL. And he's a big proponent of what causes lichen sclerosis. And we all think it's all to do with urine contact. So this is micro-dribbling. This is due to occlusion. And that's what's the driver. So when you circumcise, you don't get that occlusion anymore. And on the back of that, you reduce the incidence of penile cancer related to lichen sclerosis. So it's all to do with micro-dribbling and occlusion. And we've done lots of studies just to prove that now. We don't know what the driver is in the urine, but clearly it is contact with urine. Because if you look at two other scenarios, men who have perineal urethrostomy, and you look at females, they always have this sort of butterfly pattern of lichen sclerosis, where the urine has come into contact with that skin. So you know it's got to be the urine that's driving it.
And is that why still the typical demographic of penile cancer is the older man who perhaps hasn't been circumcised or poor hygiene? It's all that contact thing. And is that still true? Is this predominantly still older men? I mean, at Peter Nathan in the past 2 years, we've seen like quite a lot of younger men with terrible
We've
penile
seen that
cancer.
as well. Post-COVID.
Yeah, is that it? Really?
Yeah, a huge number. I mean, we've again looked at our numbers for men under the age of 50 with penile cancer, and you can just see post-COVID, it's just massive influx of young people with either pre-malignant or malignant disease and aggressive disease as well.
Renu, let's get into it. We've got a few topics to get through. So surgery is one of the things. So traditionally when we were growing up, it was like partial penectomy. Really, that was the best case scenario. There's a fungating tumor or quite a bit of tumor towards the tip of the penis and so on. But Nathan, tell us a bit about how you approach these lesions. I say it's often a biopsy proven thing. It is a skin cancer in a person who's still active. And how do you work up to say, how am I going to figure out how much surgery do we need to do for this patient? What can we get away without doing to this patient?
Yeah, look, it's easy to think of it as a skin cancer, but it's in a skin cancer with a very unique blood supply, which is, very high, rapid, very unique lymphatic drainage. And look, a lot of the thoughts around penile preservation come from the paradigms we used to have. So it used to be quite dogmatic. When I started urology, you need a 2 centimetre margin on a penile cancer. That was considered a safe margin. So, they cure them all, safe margin. Then people said, oh, that's probably not, maybe that's a bit aggressive. What about a centimetre margin? Well, that was fine. Then they moved to a 5 millimetre margin. And now most people accept probably a 2 millimetre margin is okay. There's still a little bit of debate around higher grade tumours, whether that's enough. But I think that was the first thing. So we don't need the 2 centimetre margin. Maybe a 2 millimetre margin is okay. On larger tumours, on probably 5 millimetres is what we aim for. But there are plenty of cases you would have had too where 2 millimetres is probably enough. So that was the first thing. So we don't need to take as much. Then it was a case of, well, if we're going to take it with a smaller margin, how do we reconstruct it? And it's the old theory, cure the cancer, then worry about the reconstruction. And I think it just took a while for those two things to come together. And now we have situations where you can do, skin grafts, glands resurfacing, and the penile skin's loose. You can advance the penile skin and do lots of things with it, with native skin as well, that come up with pretty good functional and sexual outcomes in terms of what the patients really want. So one of the fears around penile cancer is if I have it, I'll get the whole penis cut off. I'll lose my sex life, et cetera, et cetera. And that's from the old days when there was this 2 centimetre margin, et cetera, et cetera. Now we've got to sort of bring it forward a bit to a more modern paradigm.
Fantastic.
And is the frozen section always part of the process for you when you're doing especially partial?
Yeah, look, I used to do them, and then I found them, they get them wrong occasionally. It's hard on the pathologist to get it right. You've often got a lesion that's quite a big front, and which bit are they looking at? To look at the whole thing is quite tricky. So I think we rely a lot on our own examinations beforehand. MRI has some role in some of the more advanced cancers, although we haven't found it as useful. I'd be interested to hear what your experience is. But I don't know. I don't think there's routine. I think you've got to have bring experience to the table.
So Asif, we'll ask you for your observations on how you do surgery for these patients, how you work them up. But just by way of further background, in the UK, as you said, 12 centres only. So it's like a catchment area of 5, 6, 7 million people. Your centre looks after. So how many cases a year is that you're bringing through?
Well, I mean, to be a centre, you've got to have a catchment of at least 4 million as a minimum. Also, we're in London, so we tend to get most of North London. On average, we'll probably see anything between about 130, 150 cases in our centre.
Wow.
I mean, our discussions are 55 to 60 cases of some sort, either because they've got metastatic disease or they've come from the dermatologist, and our MDT each week. So we'll discuss 50, 60 cases.
Wow.
Not all of them will be the first presentation, but we always something to do with the management. So it's quite a big workload. 90% of the cases will be managed with penile preserving surgery now, because the majority of the cancers are either on the foreskin or the glands. So there's no reason why you have to move on to partial penectomy or subtotal. You will get the odd, advanced cancer where there's not much of the corpus cavernosum left, it's infiltrated, and you can't get away without anything but a subtotal penectomy. But I agree, as Nathan mentioned, we're now simultaneously doing skin grafting. The majority of our glandsectomies will have a skin graft and neoglands. We'll do gland resurfacing quite routinely. We're very confident moving skin around. But yeah, I'd say, when we audit it, about 90% will have penile preserving. Now, the key thing about penile preserving is to make sure that the patients are compliant with follow-up. Mm-hmm. Because one of the problems with penile preserving surgery is the high local recurrence rate. So provided they're going to be coming back for adequate, regular follow-up and also notifiers, if there is a recurrence, you can jump in, take a bit more off, and then obviously it doesn't actually change the long-term prognosis. So as long as they take that risk. As for frozen sections, as you sort of mentioned earlier, I mean, like you, we don't do them routinely. We will do them for when sort of people come back with residual disease, just to make sure we've got the margins clear this time. Sometimes we'll do frozen sections where it's not been biopsy proven, but it's obvious, but we don't like to do subtotal penectomies without getting a biopsy and making sure. So we'll do a quick frozen section and carry on with the case. We'll do frozen sections there. But yeah, you're right. I mean, I agree with Nathan. I mean, you've got such a wide area involved. Where do you take the biopsy from? So if there is one particular area, say one side margin you're not too sure about, you might do a frozen section there. But for the bigger tumours, we tend just to take them off. We'll take biopsies, but they're gone for formal histology rather than frozen section.
And is the detection of recurrence purely clinical, or do you use any imaging to follow up patients after they've had organ preserving surgery?
It's mainly clinical. They'll come in presenting as an ulcer or a lump or a new lesion. It's fairly obvious when they've got a recurrence. Just on that question about the MRI, again, we're not doing them all routinely because we tend to find that if it's localized on the glands and it's just going to spongiosum, it is in the glands. It doesn't actually add much more. The only time that we tend to do them is where there's a questionable distal corpus cavernosum involvement or extensive tumours where you want to just check for skip lesions so that you can ensure that you're going to go far down enough. You don't need to do a radical penectomy, or you can just get away with a subtotal. So we do MRIs there. But generally, I wouldn't say it's routine anymore.
Yeah.
Renu, this strikes me as we're listening to quite sophisticated workup and staging of new penile cancers with Asif and Nathan here. I'm just not sure listeners and viewers around the world will have like that experience of more than a case every 3 or 4 months coming through your department and not having that sort of expertise there. Do you think, Nathan, the issue of centralization is something that of all the cancers, these super rare cancers, surely listening to the pair of you, the way these cases are worked up and watching over my career, seeing that change, surely this is one of the strongest arguments for centralization. I know it can be quite political, but
I think, look,
don't do one of these every 4 years. Please just send it into the center.
Don't dabble.
Don't dabble. Yeah.
No, agree.
Yeah.
Okay, so what else, Renu? Lymph node dissection.
Oh, no dissection. I mean, I remember the time when, Nathan, when I was training, it would be that when someone comes in with a fungating tumour, you give them antibiotics for 6 weeks to treat any nodes that may be palpable at that time. Is that still a thing? No, it's gone, right?
Gone.
Yeah, I agree. I mean, look, if it's a palpable node on presentation, it's more than likely going to be metastatic.
Yeah.
So get an ultrasound FNA just to prove it and then move on.
Yeah.
And how do you approach node dissections? I mean, so there's the palpable, clinically positive nodes, and then there's the, someone who doesn't have positive nodes. How do you approach sentinel node dissection, superficial, deep, unilateral, bilateral?
You're right. Just divide it up into palpable and impalpable. For us, impalpable disease, we would get an ultrasound FNA, look for morphologically abnormal nodes. Mm-hmm. If there aren't any, and the FNA is negative, we'll move them on to sentinel node biopsy.
Purely based on ultrasound, no CT.
Yeah, I mean, everyone gets a routine staging CT, but the best way to pick up micrometastatic disease is ultrasound and FNA. Okay. Yeah, because CT won't detect sub 2 millimeter deposits. It's just not sensitive enough. So we'll do sentinel node biopsy, which is, as you know, radioactive technetium. You localize the lymph nodes and you make small incisions. So the morbidity is reduced considerably since we moved on to sentinel node biopsy, and that's our standard of care. For those whereby they can't have sentinel node biopsy because they've had a penectomy already, there's nowhere to inject, then you might consider doing a superficial modified and an on-table frozen section. because it's not very accurate to just inject the scar.
Yeah.
So we might do it in those situations. We won't go straight for a radical because obviously the less nodes you take out, the less likely you're going to have significant morbidity, particularly lower lymphedema and gentle lymphedema. For those who've got positive FNA or palpable inguinal lymph nodes, which are metastatic, we'll do a radical. And the radical can be either done open, or it can be done laparoscopic, or it can be done robotic. The majority of what we do are open because doing laparoscopic for nodes which are bigger than 2 centimeters is quite difficult to ensure you've got a clear margin. So we have a threshold of 2 centimeters or less for laparoscopic. Anything bigger than that goes open. And the open one, we've published over 400 cases, a joint paper with the Christie, and we use a fascial sparing technique, which has significantly reduced the morbidity. So there used to be traditionally 50% complication rates. It's gone down to about 20%.
Still considerable, isn't it? It's still a morbid thing. So 20% in expert centres still means that's a fair few patients who've got vac dressings on the groin. They're in and out. These wounds are not healing, and so on. So that's a question. Well, you've got a randomised trial about this. So comparing classic open dissection versus laparoscopic or minimally invasive. And Nathan, you moved to doing robotic assisted node dissections a few years ago on select patients. So what are your thoughts on whether minimally invasive surgery, as well as really good patient selection, but if you need to do a node dissection, do you think doing it minimally invasive, lap, robot, helps?
Look, I think it definitely, you can still get seromas and things. It's not without complication at all, but I think you don't get the horrendous sort of groins that break down and are a real problem. That's my observation. And you also get patients who sort of get very minimal morbidity, which is great. But I'd be interested to hear what the randomised trial is going to say about it, because that's going to tell more than a one centre.
Yeah, so Renu, you pulled this out. This VELRAD trial. I remember seeing this being presented at EAU when it was being developed. But the VELRAD trial is something that you and your team have led, Asif, this randomised trial of minimally invasive versus open lymph node dissection.
And finished recruiting as well.
Yeah.
Yeah, I mean, rare cancer is very difficult to recruit. And one of the issues with this one that we want to look at, so it's an NIHR-funded trial, 4 centres in the UK, was to see whether we can randomise. So one of the key outcomes was, is it feasible to randomise into open versus lab? And then secondary outcomes were looked at, length of stay, drainage, complications. And I agree with Nathan, one of the key things is you don't get wound complications. But it seems though drainage is much more longer with regards to laparoscopic versus open. So drain staying for longer. Lymphedema rates we're just analysing at the moment. Length of stay. Surprisingly, looking at just the crude data at the moment, it was only about a day's difference. So this is our technique using fascial sparing versus laparoscopic. So you save a day.
Yeah.
But it takes longer. So the procedure actually takes longer. So I can do an open radical in about 20 minutes, whereas these on average would take about 1.5 hours to 2 hours.
Yeah.
And that's not with the robot. That's just with standard lap.
Yeah. So we could do lap or robot.
Okay.
So one of the centers was doing robot. We were doing lap because costs, it cost us very, small amount to do it laparoscopically versus all the kit with the robot. So yeah, we went lap. I didn't really see if there's any added benefit. And looking at the costs, so with laparoscopy, it worked out very well.
And how did you go through the kind of the learning curve? How did you train? How do you train others?
Yeah, so my own personal training, we did an animal lab held in Norwich, and then after that, there's a couple of centres in the UK which were well established. So the Christie and Norwich were well established. So we've got a mentor from the Christie, and he did every case with us for the trial so that we get it all standardised.
Yeah.
And then I'd probably say 10, 11 cases, depending on your laparoscopic skills, is enough, particularly if you've been doing lots of, radical open groin dissections. And then you're fairly up to speed by then.
Yeah.
So Nathan, the last thing we wanted to talk about was this AI project that I've been listening to you talk about for many, many years at our weekly research meetings and so on. The idea of using photographs of these lesions into AI type models long before AI became everywhere, and running a project. So yeah, give us an update. We're really keen to hear about this.
Yeah, sure. So look, it's really frustrating when we get patients present late with lesions for 2 reasons. Often it's a patient delaying themselves because they're scared or they're worried, and that's understandable, a lot of anxiety. Or it's they keep turning up to their health provider getting given steroids and various other creams and so on. And really, they need to be triaged and referred on to someone else a bit earlier. And it's understandable. I mean, a general practitioner might only see one penile cancer in their whole practicing career, depending on where they practice and so on. So I was seeing that there were these apps around for skin cancers and so on. I thought, well, there's surely got to be a way that we can have an accessible website, not just for general public, but also for health workers, to take a photo and say, hey, this is a green thing. It's something that, perhaps go and discuss this with your GP, but it's not urgent. An orange thing, hey, this is probably something a little bit more concerning. You should see your GP fairly soon. And a red thing, you really should go and see your GP and probably get a referral to a urologist or even a dermatologist. So the idea was to be able to triage. Now, in the process of learning this and working with our biomedical engineers, we've actually discovered that you can get about 90% accuracy in actually diagnosing penile cancer. Now, which is quite incredible because I would argue you and I probably couldn't hit 90% a lot of the time, and that's why we do biopsies.
Yeah.
But it's amazing. The AI is very consistent and so on. But as I said, the app's not to diagnose. It's really to triage. And we've come up with this concept. We worked a long time on it. As you said, getting ethics through and things is difficult. We don't want to keep those photos. We just want to use them and direct. And we've come up with the name Pekka Health. So that'll be our website eventually, and within that website will be the ability to take photos. And obviously, there are many things that can mimic penile cancer. Whether it's an STI, or if it's some benign conditions can look pretty nasty, trauma, all sorts of things. So and the more we have, the best. We're working with some Danish researchers, so we're hopefully having access to a very large database there. We're working with some South African urologists, hopefully some other UK urologists. So the more data we can put into the machine, the better it will become, particularly for looking at different ethnicities and skin colours and skin tones and so on. But it's a pretty exciting project, and we think it's going to add value. And hopefully, even I say to myself, even if we got 2 or 3 cancers seen in this state earlier, it will make a difference, because the truth is, penile cancer that's advanced is often fatal. And people don't realise that. It is fatal because surgery is very good if you get to them early enough. Once they become metastatic, our systemic therapies, unfortunately, aren't brilliant, are they?
No, they're not. No, although I think immunotherapy is the way forward. So there is an EPIC trial that has just been publicised, is based in Bristol, but we're a centre there which have given immunotherapy, post-systemic therapy failures. So promising. So I think that's probably going to be the way forward.
Yeah.
Really good. And that Pekka Health will, I suppose, once you get it up and running, we'll be able to help publicise that. And
absolutely.
It's still, you've got a lesion on the penis. It's still off-putting for many patients to present with that. So this type of forum may be a way that people can share an image confidentially and get some sort of readout, or maybe the thing that leads them to come in to see a doctor to have a chat about that. So
one of the challenges must be that you really want to try and minimize the false negatives, right? You don't want to give false reassurance to patients who may have a potentially serious early lesion. So I think that's going to be part of the evolution of this project is to get that right as well.
Yeah, and look, the truth is, someone can take a photo and then 6 weeks later take another photo, and they may get a different answer.
Yes.
But all roads will lead to Rome. In other words, even for a green one, we'll still say you need to go and discuss this with the GP. Mainly because there's obviously something concerning enough for them to take a photo of it. They should get reassurance from a health provider.
I suspect people are probably doing a bit of that already, Renew, and so at least this will be a more better controlled environment to have that picture analysed rather than just stick it up on some AI thingy.
I like your trademark traffic light way of assessing these, green, orange, red.
Classic.
Hopefully it'll work.
Yeah. Awesome. Renew, did you learn anything?
Learned a lot.
That was just really good. And we need to do these rare cancers more often, don't we? And it's still a crying shame with all rare cancers, not just in GU, that there's so little funding gets attracted towards this for blockbuster systemic therapies and for surgical techniques and early detection. So, hats off to Professors Asif Muneer and Nathan Lawrentschuk for having such a passionate interest in this, improving outcomes for these patients. I think
the challenge for you guys is going to be kind of getting the next generation interested in this. Because we, especially in Australia, we see so few of these that, how do you get someone interested in this sort of training?
Actually, before you answer, Nathan, you have supervised a couple of PhD projects on this, and there are synergies between things like penile cancer and anal cancer and other things. And I know at Peter Mac, you did supervise a PhD in the anal cancer lab, because a lot of Mitch Lawrence, one of our scientific researchers, is taking fresh samples of these cancers, growing them up in a PDX, which is a very difficult thing to do. But again, his group at Monash, Renee Taylor and co, have extensive experience with PDXs in localized prostate cancer, which is also difficult. So I think that's the way it has to work, is you have to have a synergy with other things that are going on in the cancer center and use those technologies or those platforms or those interests. And do you want to make a comment about that translational stuff?
Well, Jesse and Tay, one of our urology trainees, and before that, Jonathan O'Brien, who's a trainee as well, showed a great interest in different aspects of penile cancer. But Jesse did a really lot of work with looking at organoids and growing cancers, different lines of cancers. And the idea is maybe we can have sort of individualized medicine where you can actually get the penile cancer, grow it in a lab, and then see what therapies actually work against that particular cancer. So, we that's the whole holy grail of individualized sort of cancer treatment. But I think you're right, because these rare cancers are rare. You've got to find commonality. Whether it's with vulval cancers and anal cancers that may be similar variety of HPV relation and so on, and that way you can actually get more specimens and more, bang for your buck in terms of research dollars.
Fantastic. Well, thank you very much. That was absolutely awesome. Must do more often. And I hope that the audience enjoyed that update on penile cancer. Thanks very much, gents, for that. And
we'll get you back for the Valrad trial update. Once
sure.
you've analysed all your data.
Won't be long.
And see if you're here, because your son is just starting university here, I think. So maybe you'll come back and visit us more often.
I'll probably make a few more visits. Yeah, so we'll try and catch up. I'll keep the Thursdays free.
Fantastic. Great.
Thursdays in the studio.
That's all we have time for on this episode of GUcast. We'll be back soon with more. Thank you very much.
See you next time.
Thank you.